Hi, I'm Kayla Brookshire, and I chose osteoporosis in women as the topic for my presentation, with a focus on the post-menopause population. So I want to start off by talking about a little bit of background information on osteoporosis. Osteoporosis literally means porous bones, and that's due to the fact that the disease itself causes bones to weaken and become thin and brittle. So if you look at the picture on the right-hand side, there's an image of a normal bone interior and the interior of a bone of an individual with osteoporosis. And as you can see, the image on the right, the bone with osteoporosis looks much more hollow. Those spaces are much larger than the interior of the bone of a person with normal bone density. And this weakening of the bone makes it much more susceptible to a break or a fracture. So bone is actually a type of living tissue, and under normal circumstances, old bone cells are broken down and they are replaced with new bone cells. However, the process slows with age, and ultimately more bone cells are lost than replaced. There are some signs and symptoms of osteoporosis, although they're very few. An individual may have a loss of height, a stooped posture, or they may be experiencing pain. But most people don't actually experience these symptoms, so osteoporosis is considered a silent disease. And the first indication that an individual has osteoporosis is usually noticed by their primary health care provider when their first fracture or break occurs. A healthcare provider can assess the risk for fracture of a patient with the FRAX tool. And this is a tool developed by the World Health Organization that can actually project the risk of fracture for 10 years in the future based on the patient's medical history. However, to actually diagnose osteoporosis, an imaging scan needs to be conducted. And the most common one is called the DXA, and that is a type of X-ray that scans the bone density at specific sites, for example, the hip, the spine, or the ankle. And the results of this test can show whether bone density is normal, whether there's a low bone density. For example, there's a normal decline in bone density due to age, and that in-between category is called osteopenia. But a very low bone density is abnormal, and that is considered osteoporosis. There is no cure for osteoporosis, but there are some treatments available, and these include calcium supplements, vitamin D supplements, hormone replacement therapies for estrogen or thyroid stimulating hormone, or PTH, and there's also medications available that can slow down the loss of bone, and those are called bisphosphonates. Next, I want to discuss the prevalence of osteoporosis, which affects more than 200 million people worldwide, and 80% of those diagnosed with osteoporosis are women. 30% of the entire group of women post-menopause are diagnosed with osteoporosis, and as many as 80% of all fractures in women after menopause are due to osteoporosis. 10 million individuals have been diagnosed with osteoporosis in the United States alone, with 34 million more individuals at risk of developing osteoporosis due to an already low bone density. Osteoporotic fractures cost the United States $17 billion a year currently, and that number is expected to more than double by 2040, where it's anticipated that osteoporotic fractures will cost $40 billion a year. And as the infographic shows, 1 in 3 women and 1 in 5 men over 50 years of age will experience an osteoporotic fracture at some point in their life. And this is particularly significant because the fractures incurred due to osteoporosis can definitely be fatal, and mortality occurs within 1 year of developing a hip fracture for 1 in 5 older adults. And 1 in 3 older adults, an even higher number, go on to be placed in nursing homes after experiencing a hip fracture due to the disability and the care that they need after that. So the possible risk factors for osteoporosis and the determinants that I identified in the literature include diet and nutrition, physical activity, smoking and drinking, hormone levels, which are related to sex and age, gene mutations, other health conditions and diseases that might be present, and access to health care. The first topic that I want to discuss from the literature is dietary factors and nutrition. Welch and Hardcastle note the significance of a healthy diet in preventing osteoporosis, and this study focuses on a compound called flavonoids. And these flavonoids are polyphenolic, bioactive compounds that are found in healthy foods like fruits, vegetables, herbs, and tea. And this compound is actually different than antioxidants. It's a separate chemical compound that offers health benefits for bone. And in this study, flavonoids were shown to have a positive impact on bone mineral density. And the study explained some possible mechanisms that might provide the health benefit to bone, including decreased oxidative stress, decreased chronic low-grade inflammation through the flavonoids inhibiting cytokines, which cause harmful inflammation, and through upregulating signaling pathways that promote osteoblast function. And when we talk about bone cells, the bone cells themselves are called osteoblasts. So flavonoids, they actually promote the formation and the lifespan of the bone cells. In the image below, it shows some examples of subclasses of flavonoids, and they're found in broccoli, herbs, tea, some citrus fruits, and soybeans. And those are just a few examples. There's many more. The next study also highlights the significance of diet and nutrition on impacting your risk factors for osteoporosis. And this study talks about calcium and vitamin D. Individuals diagnosed with osteoporosis are more likely to have insufficient calcium intake. And calcium is a vitamin that's necessary for bone health and neuromuscular activity. But it's also responsible for functions outside of the bone, including blood clotting and functions of the cardiovascular system. So in the body, it's really necessary to have adequate calcium levels in the blood as well as in the bone. And if there's not enough calcium in the plasma, it's actually withdrawn from the bone and taken back into the bloodstream through the process of resorption. And this is significant because women over 40 years of age, on average, only consume half the amount of recommended calcium. So there's definitely a need there for supplementation or diet modification. Vitamin D is related to calcium because this vitamin helps with calcium absorption. And without the presence of vitamin D, the calcium levels aren't maintained in the plasma, and osteoclasts are activated. So we talked about osteoblasts, and those are the good bone cells. Osteoclasts are the cells that break them down in order for the calcium to go back into the bloodstream. These osteoclasts, they break down old bone cells, but it can be problematic when they're breaking down healthy bone cells or bone cells that are necessary. And so this causes bone resorption, and similar to calcium, if vitamin D is not obtained through the diet, there's a need for supplementation, and 90% of older adults do not meet their recommended daily intake for vitamin D. So that population becomes then more susceptible to developing osteoporosis. Physical activity is known to decrease the risk for many adverse health conditions. One study investigated the specific set of exercises that best improve bone health, and the study found that a combination of strength training and aerobic activity improves bone mineral density and bone quality among postmenopausal women. A separate study by Holt and Hutchinson describes the mechanisms that cause the bone improvement. Weight-bearing exercise strengthens bones due to the resistance provided by gravity. This increased bone load stimulates the pathways for bone formation. So, physical activity actually increases osteoblast formation and increases the number of osteoblast cells. In addition, physical activity also increases balance and muscle mass, which decreases the risk of falls. A separate study demonstrated the impact of tobacco use, both smoking and chewing tobacco. And this study shows that individuals who use tobacco have an increased risk for developing osteoporosis. This risk is due to the fact that nicotine affects the following mechanisms. It decreases estrogen metabolism, and estrogen is a protective hormone against bone loss. So, with the decreased presence of estrogen, there's an increased loss of bone. Nicotine also decreases calcium absorption. It causes vasoconstriction and chronic inflammation, which decreases bone mineral density, and nicotine inhibits osteoblast and collagen synthesis. A study by Sampson cautions against the risks of alcoholism. Excessive alcohol consumption directly causes osteoporosis by killing the osteoblast cells and slowing the formation of new osteoblasts. Alcoholism damages the GI tract and reduces the absorption of calcium, which is a critical bone health nutrient. Heavy drinking increases cortisol, a stress hormone, which at chronically high levels can cause widespread inflammation, and drinking can also alter the level of parathyroid hormone. And I'll discuss the PTH hormone further in the next slide. Hormones also play a role in the risk factors for developing osteoporosis. According to the National Osteoporosis Foundation, osteoporosis is more common in women after menopause because during the process of menopause, estrogen rapidly decreases. And estrogen is an androgen hormone. It serves as a protective factor against bone density loss. A study by Krum and Brown describes the mechanisms through which estrogen provides protection against osteoporosis. One known mechanism is that estrogen suppresses osteoclastogenic cytokine production through signaling pathways and Fas ligand protein expression. This results in fewer osteoclasts available to break down the bone cells, the osteoblasts. So therefore, with fewer osteoclasts present, there is less bone resorption. This process also decreases cytokine inflammation, which can cause weakening of bones. In addition to the anti-osteoclastic mechanisms, estrogen also offers pro-osteoblast mechanisms that increase production of osteoblast cells. But an exact pathway for that increase in osteoblasts has not yet been determined from the research. In addition to the androgen hormones, like estrogen and testosterone, the calcium-sensitive parathyroid hormone, or PTH, also plays a role in osteoporosis. In a study by Neer and colleagues, PTH was found to stimulate bone formation, but also bone resorption. And that depends on the way the hormone is administered. So continuous diffusion delivery actually causes higher osteoclast activity, resulting in more bone resorption, and that decreases bone mass. But subcutaneous injections administered daily increases bone formation, or osteoblast cells, and that increases bone mass, which makes this the optimal method for preventing or treating osteoporosis. This study compared a low-dose daily injection of PTH, a high-dose injection of PTH, and a placebo injection, with regards to the effects on bone density and the reduced fracture risk as a result. Participants that received the low-dose daily subcutaneous injection had 9% higher bone density at the end of the study, 35% reduction in vertebral fractions, and a 53% reduction in non-vertebral fractures compared to the placebo group. Participants that received a high-dose daily injection of PTH had a 13% increase in bone density, a 40% reduction in vertebral fractures, and a 54% reduction in non-vertebral fractures compared to the placebo group. So this study shows that if PTH levels are not optimal, they can actually cause a negative impact on bone mass. And PTH is a candidate for supplementation in preventing osteoporosis. But it seems like that the dose really needs to be determined based on a patient-by-patient basis. One study determined that between 60 to 90% of bone mineral density is genetically determined. So this is the maximum bone density that can be attained, and that's determined by heredity and genetic factors. Mutations in key genes that regulate functions, such as hormones, including estrogen, parathyroid hormone, and thyroid-stimulating hormone, as well as mutations in collagen protein genes and vitamin D receptor genes, dramatically increase the risk for developing osteoporosis. But it's important to note that despite the fact that a large portion of maximum bone density is determined by genetics, that factors such as smoking and other environmental factors can reduce that maximum bone density as well, and that's been proven in twin studies. Diseases and health conditions may increase an individual's risk for developing osteoporosis by affecting similar biological pathways discussed previously regarding gene mutations. For example, lupus and rheumatoid arthritis cause inflammation, which over time weakens the bones. Diabetes and thyroid disorders affect hormones, and that can alter bone density. Digestive disorders, including celiac and Crohn's disease, as well as anorexia, can damage the digestive tract, and that may alter the absorption of bone-critical nutrients such as calcium and vitamin D. The medications used to treat certain health conditions may also be problematic for bone health. One type of medication are glucocorticoids, and that's a steroid drug that is commonly used to treat asthma, arthritis, lupus, and multiple sclerosis. One study found that half of patients undergoing long-term glucocorticoid therapy wind up suffering from an osteoporotic fracture. Older adults are more likely than the general population to have been prescribed a long-term glucocorticoid treatment regimen. Glucocorticoids directly affect the bone by decreasing osteoblast function and lifespan. It also causes spontaneous apoptosis of osteoblasts. So the glucocorticoids actually cause the osteoblast to rupture, even if they're still good functional osteoblasts. It impairs the formation of new osteoblast cells and stimulates more osteoclasts that break down and reabsorb bone. Glucocorticoids also directly affect molecular processes which alter bone density, and those processes include blocking the insulin growth factor, altering many different signaling cascades, and decreasing androgen hormones. Access to healthcare is also a particularly important factor related to osteoporosis risk. Individuals with health insurance and a higher income are more likely to have the screening available, which would let them know early on about calcium or vitamin D deficiencies. And they would also have access to those screening factors, like the FRAX tool, in order to predict their risk for developing osteoporosis. More than 11% of individuals diagnosed with osteoporosis are minority women with low access to health care. Although hormone replacement therapy is a highly effective treatment for the prevention of fractures in menopausal women, minorities, including African Americans and Hispanics, are much less likely to receive hormone replacement therapy than Caucasians. This is my web of causation for osteoporosis, and I'll try to explain a little bit about the choices for my diagram before getting into the specific factors. So in the center of my web, I have osteoporosis, and around osteoporosis are all the factors that I've determined from research to play a role in the risk for developing the disease. And the circles are categories for the factors. And I chose biological factors, structural factors, cultural factors, and personal choice as my categories. But even these are interrelated. So the solid lines are direct relationships between a category and a specific factor, whereas a dashed line is a relationship between two specific factors. So for example, diet is probably the most interrelated variable on my diagram because there's so many different categories and influences on diet and dietary influences on other factors as well. So structural factors influence diet because we may eat what is available. For example, food deserts, as we discussed in class, play a role in getting nutritious and healthful foods. So whether or not a grocery store is accessible can definitely play a role on diet, or whether the only food option is fast food. Personal choice also plays a role in influencing diet, as does cultural factors, because living in the South, we may have a different diet than individuals of other regions. Diet can also impact another specific factor, body frame, though body frame has another influence of biology. So genes and diet both together influence an individual's body frame. Diet can also be related to comorbid disease. So an individual with a poor diet could definitely have worse disease outcomes and other diseases present, such as type 2 diabetes, heart disease, things of that nature. But also, comorbid diseases, such as celiac disease, can influence diet. Biological factors influence diet as well, as we discussed that vitamin D plays a big role in osteoporosis. And some of the sources for vitamin D include dairy, but many individuals are lactose intolerant, and therefore we can see that biological factors influence diet as well. So for our specific factors, we have age and sex, which are largely biological factors. We have hormones, which are the result of biology in terms of the genes for hormones functioning properly, when menopause occurs, and things of that nature. But also, hormones are affected by access to health care and treatment compliance, especially for women, because after menopause, there may be a need for hormone replacement therapy, but if an individual cannot access adequate health care to receive that hormone replacement therapy, or if they make a personal choice, or if there's a culture factor at work there, they may not comply with the treatment. Body frame, as we mentioned before, is a specific factor. Individuals with a smaller body frame are more likely to develop osteoporosis, but being obese is a risk factor as well. So we want to maintain a healthy BMI in order to reduce risk for osteoporosis. Access to healthcare, comorbid disease, physical activity, smoking, alcohol abuse, and treatment compliance are other factors as well that play a role in osteoporosis. I'm a student in the graduate gerontology program So I chose to explore a gerontological perspective on osteoporosis. And falls are a concern in gerontology and any care partner that works with older adults because falls have very severe statistics. 12 million older adults fall each year in the United States. That's 1 out of every 3 older adults fall each year. Older adults are hospitalized for falls greater than any other disease, and that's a 5 times greater occurrence. 90% of hip fractures are associated with a fall, and falls are a major cause of disability and mortality. Falls are the leading cause of injury death in adults over age 65, and many older adults wind up restricting their activity after a fall for fear and lack of self-confidence in their ability, which leads to physical decline, depression, and social isolation. So how do falls relate to osteoporosis? Well, an individual with osteoporosis has a higher risk of worse outcomes from a fall. So even a minor fall can have grave outcomes in individuals with osteoporosis. Individuals with osteoporosis are much more likely to break a bone from a fall due to their weakened bone structure. One study found that osteoporosis and age are the 2 most significant risk factors for incurring a hip fracture due to fall. It was also found that individuals with osteoporosis are more likely to fall in general. 63% of the women in the study were at risk for falling due to muscle and balance issues compared to women of the same age with higher bone density. The study recommended that an increase in screening for fall risk factors and for low bone density in women after menopause in order to increase treatment and interventions as a preventative strategy. Despite the substantial public health concern for increasing prevalence of osteoporosis, few interventions exist. Most individuals diagnosed rely solely on medications and suggestions provided by their primary healthcare provider. But I was able to locate one particularly promising pilot study for a community-based intervention. And the researchers in this study designed a multi-component program entitled Osteosize. And this program aims to decrease adverse health outcomes associated with osteoporosis. This is designed to reduce fractures and falls and to generally strengthen bone health. And this program was developed in Australia, and it's designed for older adults. The program consists of education, exercise, and lifestyle change strategy components. The OsteoEd component involves 3 community seminars in a 12-month period in order to educate participants about the risk factors for osteoporosis and the importance of maintaining an active lifestyle and choosing a healthful diet. The Osteosize, or exercise component, involves a weekly 60-minute exercise routine, which is comprised of various exercise training, including high-velocity progressive resistive training with free weights, moderate impact weight-bearing exercises, and these are lunges and jumps, high challenge balance and mobility exercises, core muscle stabilization, and flexibility and stretching. And these exercise sessions take place at a specific facility with trainers that can instruct on the Osteosize battery of bone-friendly exercises. So they have specific exercises that are designed to build bone but not overstrain them. The last component is the OsteoAdopt portion, and that involves small group sessions that teach cognitive and behavioral strategies to enhance motivation in order to continue physical activity outside of the training center. The buddy system is encouraged as a way to increase social support and motivation in order to continue the program. As Osteosize was only a pilot program, there's not really any data that proves that it's effective. However, within the design model, The researchers intend to measure the effectiveness of the program through bone mineral density scans, functional muscle power assessment via a timed stair climb test, monitoring falls via documentation on monthly fall calendars, through recording body mass index, body weight, height, and through self-report from participants in a food diary on their nutrition. One limitation of this intervention, aside from lack of data, is that the cost may be prohibitive for an osteosize program in many communities. It is also necessary to educate the community about the need for participating in osteosize. Otherwise, the community may not be aware of the benefits. I imagine that healthcare providers could refer individuals to such a program, or a public health campaign may be effective in advertising the intervention. However, I'm concerned that transportation may be a barrier for older adults to get to this sort of program. One additional critique that I have is that the program targets adults over age 65, but based on the previous research, we know that menopause has a negative impact on bone density, so I believe that the program should be considered for individuals of all age groups in order to prevent the risk factors for osteoporosis before it really has a chance to develop. The 2004 Surgeon General Report on Bone Health and Osteoporosis was instrumental in advancing awareness and implementing health policy for the disease. As a direct result of the report, a national action plan was developed by a coalition of organizations, including the American Society for Bone and Mineral Research, the National Osteoporosis Foundation, the Osteogenesis Imperfecta Foundation, and the Paget Foundation. And this report highlighted current successful policies, including praise for a 2005 bill in Maine that provides prescription drug benefits for the coverage of osteoporosis medication in the elderly population. The FRAX tool, developed by the World Health Organization, was noted as a significant advancement for screening, early detection, and treatment of osteoporosis. The success of the Own the Bone online program, developed by the American Orthopedic Association, was discussed in the prevention of secondary fractures. This program allows patients to keep track of their prevention measures, including supplements, exercise, smoking cessation, and fall prevention, with an online program. Participants showed up to 4 times the improvement on these categories compared to non-program participants. So the On the Bone program was helpful, and once an individual came in to a hospital that participated in the program with a fracture, they were given access to this online program in order to keep track and monitor their risk for developing a second fracture as well. And they were able to self-manage their condition better due to this program. The National Action Plan for Bone Health provided 4 goals: developing a Bone Health Alliance, promoting bone health and disease prevention, improving diagnosis and treatment, and enhancing research. Since the publication of the document, the National Bone Health Alliance was developed as a public-private partnership to promote bone health, improve bone disease diagnosis and treatment, and improve research. Annual meetings are being held and attended by members of the Alliance. While this report has been successful in increasing awareness among organizations and government agencies, I don't really feel like this success has translated well into an increased awareness of the at-risk population. There are still very few interventions available, and a focus needs to be applied to designing and implementing successful, evidence-based prevention and treatment programs. In conclusion, osteoporosis is a major public health concern which will continue to grow with the projected population aging. Research has shown that an interplay of factors contribute to overall risk for developing osteoporosis, and these factors include categories such as biological, structural, cultural, and personal choice, and specifically, those factors are interrelated as well. Few health interventions currently exist despite a strong need for such programs. The osteosize program appears promising, and research updates should be monitored to determine success of the program in order to possibly implement it in the United States. Interventions are highly necessary due to the adverse impact osteoporosis exerts on fall outcomes. And the National Action Plan for Bone Health has increased awareness among key agencies regarding osteoporosis. However, much more needs to be done in order to educate the public on preventative strategies and risk factors, as well as to increase research funding for the development of new treatment options and interventions. And these are my references. So thank you for listening to my presentation.